So we'll get started with our resident portion of the program. Our first speaker will be Dr. James Alrassi, who'll be speaking about illuminating voices, tracking the evolution of laryngoscopy through innovations in lighting. James.
Just continuing my stretch of history talks here for my last year in residency. It'll be hard to follow that talk, though, Dr. Yamchuk. Just pull this up. Okay, so yeah, the title of my talk is Illuminating Voices, Tracking the Evolution of Laryngoscopy Through Innovations in Lighting. And, you know, there's a lot of primary source research that kind of goes into this, but more or less what I want to do for you guys today is build a narrative around the idea that innovations in lighting could be a stand-in for innovations that we saw through laryngoscopy. The two go hand in hand. No disclosures. This is a brief outline of the talk. I'll go over some of the early foundations of the field of laryngology and then actually start discussing some of the first instances of direct visualization of the larynx and then how different advancements in illumination kind of led to the current technology that we use today. Okay, so one of the earliest descriptions of instrumentation of the airway could actually be dated back to 3000 BC, and this was a relief slab found in the burial chamber of King Degir, and this was believed to demonstrate one of the first tracheostomies. And while not, you know, the earliest instances of the larynx, it goes to show you that there was a general interest in the ancient world. The first time, though, that we actually get the word larynx doesn't come until ancient Greece. And it was in Aristotle's treatise called Parts of the Animals that he actually coins the term larynx, which is basically Greek for anterior neck windpipe. The limitation, though, within the ancient world, both in ancient Greece and ancient Rome, was there was a big stigma around dissections because they thought that defiling the body would defiling cadavers would defile the human body. And so a lot of their research or innovation were based off of research with animals. But still, despite this, even through the ancient Roman period, we were able to gather a pretty good fund of knowledge on the anatomy of the larynx, including the different musculatures and nerves that innervate. But it wasn't really until the Islamic Golden Age that we start seeing canons of medicine that describe the larynx as the etiology behind hoarseness and difficulties with swallowing. Pictured here is Abu Bakr al-Razi, no relation, Persian polymath who was practicing at the time in Baghdad. And I think there's it's easy in history to kind of talk about different eras as these standalone periods, but they should really be seen as a continuous narrative with reliance on the prior foundation or funds of knowledge in order to kind of push the fields forward. So, I mean, while the Islamic Golden Age had a lot of innovations themselves, they were relying on translations of the ancient Greek and Roman texts that kind of laid the foundations. And a century later, the works of Ibn Sina, also within the Abbasid Empire, he put out with his own treatise and talking about different types of homeopathic remedies for treatments of dysphonia, which he attributed to kind of issues with the larynx himself. But it's really not until the European Renaissance that we have this, I'll move this away a little bit, that we have one of the most anatomically accurate descriptions of the larynx itself. And Andreas Vesalius, a Dutch anatomist working in the 16th century, put out what is to this day seen as one of the most accurate descriptions of the human body. And it was in his treatise that he actually outlined the different subsites within the larynx and identified the true vocal folds. And then this work was just furthered within the European Enlightenment with Morgagni, who identified the laryngeal ventricle, also known as the Morgagni ventricle, which we don't really use today. But the limitations all up until this point was that they were working with usually either dead animals or dead humans. What eluded us was the visualization of the larynx in a human being. And it was not until the mid-19th century that we were first able to do that. And pictured here is Manuel Garcia, who's a professional singer. And he got the idea of redirecting light into his throat in order to examine his own voice box when he was passing a church and saw the light reflecting off one of the stained glass mirrors. And so he was widely credited. He published his work within the medical journals, even though he's not a physician himself, describing the motions of the larynx and the production of sound. And this really kick-started a space race in laryngoscopy. And so you had physicians across Europe who started using or experimenting with different light sources in order to better visualize the larynx. Picture here is Serzmak, who was working at the time in Hungary. Well, and the way it's described was that it wasn't so as sunny as Spain, and so the abundance of sunlight wasn't there. And so he started working with kerosene lamps in order to examine his patients' larynxes. The next big jump forward in laryngoscopy was direct laryngoscopy, and it's intimately tied with the discovery of the incandescent light bulb. So incandescent light bulbs, I'm sure we all still had those kind of growing up, but was reliant on a filament in which an electrical circuit would run through, heat up the filament, create illumination. The only limitation here, though, was that it would heat up, and so the exams of the larynx would be pretty short and limited by how hot the distal tip of the laryngoscope got. So I'm sure this looks familiar to all the residents. This is the Hopkins rod, named after the British physicist Harry Hopkins. And the big innovation here was, optical rods were widely in use, but he patented the first cylindrical outer casing, which aligned all of the optical rods to give this magnified image. And what he was able to do was pair this with an illumination port in which these more powerful halogen lamps were able to create much wider illumination and therefore much brighter visualization of the larynx. And this is at the time that we also start seeing all these, the advancement in our understanding of the way that the larynx produces sound and it protects our airway. Around this time, there was also innovations going on in the field of GI, actually, in which they were experimenting with flexible gastroscopy. And a group of ENTs within Japan, Dr. Mawasaki and his colleagues, thought, well, this could be easily translated into ENT, and they were the first to put these sleek new fiber optic scopes that were flexible through the nose in order to examine the larynx. Which really gets us to kind of the distal chip endoscope, which we kind of see widely in use. While the prior fiber optic endoscope relied on transmission of the image through the actual optical rods, the distal chip endoscopes captured the image at the tip of the endoscope and then transmitted it digitally to the screen or monitor that the clinician's using, which allowed for a much higher definition image, but it also did not take as much space within the endoscope itself, so it allowed for a greater room for not only illumination, but other side ports for instrumentation and like ventilation. So where do we go next? I mean, there's a lot of interesting work going on. This is microendoscopy. And the idea behind microendoscopy is that being able to get histological evaluation at the time of endoscopic eval. And the way that this is still kind of preliminary work, but a lot of the work is based off of thoracic surgery. And they use a fluorescence in order to detect certain dysplasias of the lower airway. And as you guys imagine, as this technology kind of advances, especially in those patients that come in with cancer of unknown primary, using fluorescent microendoscopy to do a thorough evaluation of the upper aerodigestive tract without having to biopsy targeted sites could be huge. And then the other, which is actually in practice already, is narrowband imaging. And the idea here is that within the spectrum of visible light, it could be broken up into short, middle, and long wavelength. And the different wavelengths penetrate tissue at different depths, with the shortest wavelength kind of penetrating tissue pretty superficially, longer wavelength penetrating a bit deeper, and the shorter, the middle wavelengths penetrating at kind of this middle area. And that's where the vasculature of mucosal epithelium is located. And if you could kind of filter out that middle wavelength, you could identify vascular irregularities just beneath the mucosa, which is very intimately tied to certain types of early stage cancers and dysplasias. So in all, I hope I demonstrated that the innovation of laryngoscopy itself is intimately tied to innovations in illumination, and that there's still some really interesting directions that we could go with the cool tools that we get to use on a daily basis. These are my references, and thank you.
Very good. Thanks, James, who aptly serves on the History and Archives Committee. Any questions for Dr. Alrassi? Oh, with a microphone?
That's all right, I'll just go.
Oh, is it
So
here?
thank you. It's nice to see this interest in history, which I think is unfortunately a waning and disappearing thing in our field. Is your perspective? So two questions. You had some interesting collaborators on there who aren't part of this department.
Yeah.
Dr. Coltine and someone from Cornell. How did you come up with that trio? First question.
So Dr. Rameau, actually, so she's at Cornell. She was also the chair of the History and Archives Committee at the Academy, and she was asked to write a textbook chapter on the history of laryngology. And so she asked me if I'd be interested in writing it, and then just by virtue of doing research on the history of laryngology, I got a lot of kind of information about laryngoscopy and figured put the two and two together.
And the second question has to do with, well, it's really two parts. You didn't mention anything about, you know, deep learning algorithms and all this AI stuff going on, not just getting an image, but interpreting it, which I think is probably parallel to this. So that, and also the other issue that comes up is that of health disparities. As this technology advances and becomes so complicated, expensive, and you know, high tech, it seems like the disparities are just going to increase tremendously around the world between, you know, countries with challenges and resources and those that have more rich resources. So how are those two things, the deep learning and the equity issues, going to be addressed?
Yeah, you're right. There's a lot of really interesting research going on around AI, not just with voice interpretation, but image interpretation. I kind of wanted to focus on the instrument itself, like the tool that is being used in order to capture images. And so I kind of like steered away about looking into the future directions with AI and focused on how are the actual image capture and illumination going to be changing. As for kind of disparities within these technologies, you know, there has to be a very specific need that I see for these other forms of technology. Like even narrowband imaging, most new distal chip endoscopes have that capability. We have it actually in the county hospital. Our distal chip endoscopes are capable of doing narrowband imaging. I just don't think its clinical application is widely in use just yet. And so my point here is I don't think that this technology is going to be taking over as quickly as, say, just the basic innovation of an endoscope and direct visualization of the larynx was.
That was great, James, and I want to congratulate you not only on this presentation, but on something that everyone here should look at and consider when they consider future direction and fellowships. What you did is you started very early. Once you decided you're going to be a laryngologist, you started very early to become very involved with the local and regional and national and soon enough international levels of laryngology. And you really kind of designed your path toward to be a laryngologist. And I'm quite sure an excellent laryngologist. So congratulations on that also.
Thank you, Dr. Howell. Appreciate it. Thank you so much. All right, thank you.
Thanks, Jim.